What's up, future doctors? Welcome back to Medical Notes Hub, the channel that turns your thickest textbook chapters into notes you'll actually remember on exam day. Today we're breaking down. Now, we all know that bronchiectasis is permanently dilated. Damaged bronchi that can't clear mucus. Damaged mucus infection, more damage. That loop explains everything. Symptoms include chronic productive cough. Cilia are broken mucus pools. Coughing is the backup pump. Worse in the morning because mucus collects overnight. Purulent, foul sputum. Stagnant mucus gets infected, neutrophils flood in. Dead bacteria plus dead neutrophils equals pus, and anaerobes give it that smell. Recurrent chest infections. Dilated bronchi act like bacterial hideouts. Antibiotics clear the infection but never the reservoir, so it just comes back. Hemoptysis. Chronic inflammation grows fragile new bronchial vessels that rupture with coughing. Small streaks are common. Massive bleeding is an emergency. Dyspnea, mucus plugging plus destroyed lung tissue equals air trapping and poor gas exchange. Wheeze, narrowed, inflamed airways make airflow turbulent. Pleuritic chest pain, infection reaches the pleura, so every breath stretches inflamed tissue. Fatigue and weight loss. Chronic inflammation burns calories, appetite drops, breathing itself becomes work. On examination, coarse crackles. Small mucus-filled airways popping open on inspiration. They often decrease after coughing. High-yield exam pearl. Rhonchi, low-pitched snoring from air vibrating through mucus in the bigger airways. Digital clubbing. Chronic inflammation allows growth factors such as VEGF, PDGF, to stimulate tissue growth at the fingertips. Cyanosis. Poor oxygen exchange means more deoxygenated hemoglobin in the blood. Cor pulmonale, the late-stage red flag. Low oxygen causes pulmonary vasoconstriction, that raises pulmonary pressure, and the right ventricle fails. Investigations include high-resolution chest CT is gold standard. Findings include signet ring sign. The dilated bronchus becomes bigger than the pulmonary artery sitting next to it. Memory trick. Bronchus is the ring, artery is the stone. Tram-track sign. A dilated bronchus viewed side-on shows two thick parallel lines, like railway tracks. Loss of bronchial tapering. Normal airways narrow as they go outward. In bronchiectasis, elastic tissue is destroyed so they stay wide, and you can even see bronchi near the pleura where they shouldn't be visible. Severe cases show cystic, mucus-filled sacs. Chest X-ray is less sensitive, but shows tram-track opacities, ring shadows, and thick markings. Spirometry shows an obstructive pattern, FEV1 down, FEV1 by FVC down because mucus blocks forced expiration. Bloods, CRP and ESR for inflammation, neutrophils for bacterial infection, eosinophils raise suspicion for ABPA, immunoglobulins screen for immunodeficiency. Don't forget sputum culture to identify organism, sweat chloride for cystic fibrosis, and bronchoscopy if you suspect a foreign body, tumor, or obstruction. Every treatment exists to break that mucus infection damage cycle. Airway clearance is the cornerstone. Chest physiotherapy loosens mucus, postural drainage uses gravity, ACBT and huff coughing move it out. Oscillatory PEP devices like flutter or a cappella vibrate the airway to loosen secretions. Hypertonic saline draws water into mucus, thinning it for easier clearance. Antibiotics. Culture guided for acute flares, long-term macrolides to cut down future exacerbations, and inhaled antibiotics for chronic pseudomonas. Bronchodilators help if there's overlapping wheeze, asthma, or COPD. Vaccinate against flu and pneumococcus. Prevention beats treatment. And surgery, usually a lobectomy, is reserved for localized disease, recurrent severe infection, or massive hemoptysis. That covers everything you need for your exams on this topic. Drop your questions in the comments, subscribe for more high-yield content, and good luck with your studies.